So one of the things I think this case kind of highlights in a way is that sort of the elephant in the room for antimicrobial stewardship, what is our biggest area of need is in the outpatient setting. Like we have gotten pretty good, I think, of learning how to create programs and implement programs for antimicrobial stewardship on the institutional side, and that's slowly starting to spread towards long-term care facilities, which is very important because they are a reservoir for many different types of resistant bacteria. But in the outpatient setting, we really haven't figured out how to do that very well. And part of this is diagnostic. Antibiotics are prescribed usually before you know exactly what you're dealing with. When someone comes in with a urinary tract infection, you don't wait for the culture result to come back before you start them. So for some infections where it's fairly characteristic what the infection is going to be due to and that they actually have an infection, that's okay. But for other ones like upper respiratory tract infections where a large percentage of antimicrobial use is not necessary, we need better diagnostics to figure out who has a cold and who has sinusitis or a bacterial infection of some sort. In terms of how we get there to have better diagnostics in the clinic, the first point is that they need to be developed, and they're getting there in some ways. But once they are there, we need to incentivize their use. So in terms of reimbursement for clinicians to utilize these, we have to get them to do that in some way. I mean, obviously, first they need to know of their existence. But secondly, if it takes a little bit more time to do so, they need to be reimbursed for doing that, or if there's an extra step involved. So increasing the diagnostic certainty is important. We need to help people get there.